Hi, everybody. I think we're almost ready to get started here. Okay, it's 2:30 my time, and my name is Carla Haravi, and I want to thank you so much for inviting us to come to your meeting again. Special thanks to Susan Fleener, Jenny Baumert, and Sherry Young. And this is going to be a part 2 webinar. Denise Wilson had done a part 1 webinar about how clinical documentation specialists can help in the denial and appeal world, and we were asked to do a part 2. So that's what we're going to do today. And I also want to thank you for your patience. I was sick last week. I couldn't talk, and I've got my cough drops and my drink, and I have my fingers crossed we'll get through this. So I also want to thank Kristen McLeod. She's my assistant. She'll be monitoring the question box. I can't hear you, so if you're having any technical difficulties or if there's any problems, please use the question box in your in the control panel, and she will get back to you. So, okay, so I think we will get started then. Okay, now we'll get started. So you should see a control panel that looks like this, and you are muted, and there are handouts in this area that you can download the handouts if you want, and then down in this area there's questions and comments, and if you have any technical difficulties, please let Kristen know, and she will help you to resolve whatever the problem is. And then as far as questions about the webinar itself, hopefully there will be some time left at the very end, and we'll go over some questions, and hopefully we'll get to answer some. Otherwise, we will gather all of your questions, and then I will answer them hopefully in the next week or so, and I'll get everything to Susan, Jenny, and Sherry, and then they can distribute the questions and the answers to you folks. Okay, just a little bit about me. I'm a vice president at PayerWatch Appeal Masters, and I've been a nurse for a long time. And one of the highlights of my career was at my local hospital. I was a CDS for quite a few years. I became the manager, and then I also developed a hospital-based denial and appeal program. So all told, probably about 12 years, 11 or 12 years doing that. And then I came to Appeal Masters about 6 years ago. Just a little bit about AHDAM, continuing the housekeeping here. AHDAM is the Association for Healthcare Denial and Appeal Management. It's the nation's only association that's dedicated to healthcare denial and appeal management. And our mission is to support and promote the professionals working in the field of healthcare insurance denial and appeal management through education and collaboration. Our vision: we want to create an even playing field where patients and healthcare providers are successful in persuading medical insurers to make proper payment decisions. So that's what we're all about. Our website is there, www.ahdam.org, and AHDAM was created through the generous support of PayerWatch, who is also my employer. Continuing education certificates will be distributed by your ACDIS chapter, the Washington, Idaho chapter. Pardon me. Oh. Okay, last we saw you, Denise Wilson presented the role of the CDS in management of clinical validation denials on 12/7. So we were asked to do a part 2 webinar regarding what CDSs can do up front to help prevent and substantiate the clinical records so we can try to avoid or lessen these denials that everybody is getting. And it was very interesting. Poll results revealed last time that 64% of you sometimes, rarely, or never help with appeals writing. So, so that's what we're going to talk about today. We're going to talk about what you can do on the front end to maybe not do the actual appeal writing, but to help those who are writing the appeals. There's a lot that you can do. Our objectives today are to describe 3 courses of action clinical documentation specialists can utilize to help prevent clinical validation denials. And I'm hoping that by the end of this webinar, you'll be able to describe a lot more than 3, but I'd be happy with 3. All right, we are going to do a poll before we get into the meat of this. So, when clinical validation denials are received by your hospital, is the denial rationale ever shared with your department? That would be a yes or a no. Okay, just give me 1 second to launch this. Okay. Interesting. We have about a 50-50 split right now. Let's just give it a little more and see. Okay, we're up to 70% have voted, 72. Okay, just a couple more seconds here. Okay, all right, so we have most folks have voted. We have about a 60-40 split here. And okay, that's actually a little better than what I expected it might be. I'm glad to hear that, because that's the first step. You have to know what's being denied before you can have a real good understanding about how you can help to prevent those denials. So that's awesome. Well, maybe in a year or so, or maybe we'll talk again sometime, and it'll be even better than 60-40. But that's good. I'm glad to hear that. Okay. And we're not advancing. There we go. Okay, we're going to start out just with a couple of definitions, and we're going to start out with just a little teeny review of what Denise covered in December. So just so we're starting on the same page, clinical validation is a process which involves a clinical review of the case to see whether or not the patient truly possesses the conditions that were documented. That came from the RAC Statement of Work back in 2011. So it's been around, it's been around for a while. And AHDAM told us in 2018 the same thing, just a little different wording. Clinical validation audits determine whether diagnoses documented in a patient's record are substantiated by clinical criteria generally accepted by the medical community. In other words, a clinical validation denial is essentially saying, doctor, you misdiagnosed your patient. This diagnosis just did not exist. I don't care that it's documented all over the chart or it meets the definition of a secondary or a reportable diagnosis. Clinically, it wasn't there. Clinical validation cases are not coding denials, and we're not going to win them with just coding rationale. Now, you can use some coding rationale sort of as icing on the cake, but you're not going to win these denials based just on coding rationale, because that's not the base of the denial. Most of these diagnoses are actually coded correctly. All of the coding clinics and the guidelines, everything has been followed, so they're coded correctly. So we're not going to win by fighting for clinical or for with coding rules and regulations. So what prevention measures can CDI take to prevent or lessen denials? And I like this picture because that's what it feels like to me a lot of times. There's this big entity out there, and they're just pushing and pushing and pushing, and we're pushing as hard back as we can. So, but I think we're getting there. One way is that you folks, the CDSs, doing your CDI job every day, appropriate queries. And I mean, that's your main job, to query when it's appropriate. And thank goodness we have AHDAM and ACDIS guidelines for achieving a compliant query process, which really lays out so nicely everything you ever wanted to know about queries. And I don't know if you've all had a chance to read the 2022 update. It came out December 14th. There's one thing in particular that really stuck out to me, and we are going to talk about that today. But the other things we're going to talk about today are when to query includes to seek clarification when it appears a documented diagnosis is not clinically supported or is conflicting with the medical record documentation, clinical validation. To determine if a diagnosis is ruled in or it's ruled out. To clarify a diagnosis on an ancillary note that has been signed but not addressed by a provider. For example, and this is all part of the 2014 update, the example part. For example, if the nutrition note states severe malnutrition and the note is signed by the provider, but the provider does not address the diagnosis within their documentation. So they're telling you now this is an appropriate time to query. So we're going to look at some actual case studies, and these are real case studies, and I did not include queries from our clients. Some of them weren't quite the best, and others they don't necessarily give them to us. And then another thing is we don't know when a case has been overturned. The rationale for the overturn is not usually given. So I did pick some cases though, and some cases that a query would have been very appropriate. So we're going to go through some real cases here. So coded and billed. Acute and chronic diastolic CHF is a secondary diagnosis. Clinical scenario. The provider referred to the immediate previous admission that the patient had acute and chronic diastolic CHF. Current status documented throughout the whole hospitalization. Patient was euvolemic, BNP was 27, lungs were clear, negative chest x-ray, received a home dose of diuretic oral, and it was only a 2-day hospitalization. And it was one of those copy and paste things, documentation said the whole way through, other than that one statement at the beginning that the acute and chronic was in a previous admission, a recent one, but the rest of it said acute and chronic diastolic CHF. There was not a query or an answer. So even though the documentation was consistent with documentation of the diagnosis, the clinical criteria didn't match. So as you could see from the clinical criteria that we had there, you would expect something if somebody had an acute exacerbation of diastolic CHF. You probably are going to see more signs and symptoms, treatment than what was there. So there's a mismatch. So why a query was needed? As AHDAM and ACDIS, the guidelines tell us to seek clarification when it appears a documented diagnosis is not clinically supported or conflicting within the medical record documentation. So that was a fantastic, I thought, example, classic case where a query might have helped to prevent that case from being denied. So a potential query to fit that particular case: click clinical indicators, just as we laid them out, just as it said in the medical record. Per the home medications, it seems that the home dose of Lasix was ordered, chest A was negative, BMP 27, euvolemic, PH&P, state 2 was previously admitted, 4, acute and chronic CHF, and then the progress notes indicate a current diagnosis of acute and chronic diastolic. Please clarify the status as related to the current admission. Acute and chronic CHF ruled in, ruled out, ruled in. And, it's always good to say, please document additional supporting information or mitigating factors, because it could come, the provider could write in response to the query, yes, acute and chronic diastolic CHF was ruled in, but if it's not written why, it's not going to help. So we really want them to give that extra information. Maybe there's something they forgot to write. Maybe, who knows? But maybe there's something that we're not aware of. Let's look at your next one here. Acute respiratory failure was coded and billed. The scenario in this case, it was a 26-year-old female. She was admitted for an unintentional fentanyl overdose. She was intubated, but her ABGs, her pulse oximetry, they were all normal, no increased work of breathing. And at the time of the intubation, they wrote that she was intubated for airway protection. Then later on in the medical record, it said acute respiratory failure and airway protection. Okay, so we have a mismatch here too. The clinical picture that we see doesn't really support respiratory failure. That's not saying that she wouldn't have gone into respiratory failure if she hadn't been intubated, but at the point of intubation, was she really in respiratory failure? There was not a query or an answer. So why a query was needed per ACDIS and AHDAM's guidelines, the same as what we talked a few minutes ago, to seek clarification when it appears a documented diagnosis is not clinically supported, and to determine if a diagnosis was ruled in or was ruled out. A potential query for this case might have been the procedure note of the date states the patient was intubated for airway protection. Then the progress notes of dates state intubated for acute respiratory failure. Put down your clinical indicators just as they came out of the medical record. The ABGs were within normal limits prior to intubation per the ED note. Continuous pulse oximetry prior to intubation, all the stats are greater than 96%. No documentation of increased work of breathing noted. Please clarify the respiratory diagnosis. Acute respiratory failure ruled out, ruled in. And again, we're going to say, please document the additional supporting information or mitigating factors. Or maybe there's something else. Maybe there's something we don't know about. Excuse me. Okay, now this one, it really wasn't a date of service of January 2023, but I made it because the AHDAM guidelines changed as of December 14th. So we're going to pretend that this patient's date of service was in January 2023 after the updated AHDAM and ACDIS query guidelines. So coded and billed. Severe protein calorie malnutrition is a secondary diagnosis. The clinical scenario was a registered dietitian's note contained clinical support for and the nutritional diagnosis of severe protein calorie malnutrition. The note was co-signed by a provider but it wasn't anywhere else to be found in the medical record. No query, no answer. Why a query was needed? Because per those guidelines, recently updated in December, if the provider does not address the diagnosis within their documentation, just co-signing isn't enough. Need to query about that. And this has been a rather common situation for a lot of years, and we've seen a ton of nutritional denials due to that scenario, and they've been hard to argue. And I'm not going to say we haven't won some, we have, but there's a lot that we haven't won, and I think this is where you guys can really make a difference, because I really think there's going to be increased denials of nutritional diagnoses if the only mention of a nutritional diagnosis is in a non-provider's note, even if it is signed by a provider. The payers look at the guidelines just as we do, so they're going to look at that and say, "Oh, okay, now we have proof. We need to have more than that. They need to write a query in that situation." So I really think that there's going to be increased denials for that, and I'd be looking out for them. Not just looking out, but what can we do to try to mitigate that a little? Potential query example: severe protein calorie malnutrition was documented on the registered dietitian's assessment and co-signed by a provider. Clinical indicators, whatever they were, you write whatever the clinical indicators were. Please clarify the nutritional status of this patient. This is just an example: malnutrition, severe protein calorie malnutrition, or other. Please specify. So please keep your eyes out for those, and I think they're going to be coming. Okay, sepsis. We all know and love sepsis. So sepsis was coded and billed as a principal diagnosis. Now this is a little bit different from what we talked about before. The clinical scenario for this: SIRS criteria were met, thought due to a UTI. Antibiotics, sepsis pathway was started. On day 2, the infection wasn't suspected any longer. They cut the antibiotics. Patient was discharged. Fast forward, about a year later, sepsis was denied on a clinical basis. Now, looking into it a little bit, we saw that the case was coded and billed with sepsis as a principal diagnosis, but a discharge summary was done after the case was billed, and it actually ruled out sepsis in response to a query. So this is, so I'm just going to say that again. The case was coded and billed, then the discharge summary was done, and the query answer was in the discharge summary that was not considered when it was coded and billed. More common than you might think. So something to consider: does this happen at your hospital? Are queries being written, but they're final billed prior to an answer? It happened at the hospital that I came from, and it was a problem. We had to get a committee going, and lots of people from different departments, and we got a good process to help prevent as much of that as we could. One of the things that enters into this is something called the DNFB list. It's discharged but not final bill. Hospitals want to keep the number of those cases down, because if you have a lot of cases that the patients have been discharged, but they haven't been final billed yet, there's not a good cash flow coming in. So they really want to get things coded and billed as quick as they can. But it might be worthwhile to see, are excuse me, are cases being held when a query has been written and the discharge summary hasn't been done yet? Are they being billed? Might be something to look at. Something else to consider. Are CDSs looking at discharged medical records to look for unanswered queries, or maybe to look for query opportunities prior to billing? This is a tried and true way to help prevent some of these denials that we see. Now, I get it. I understand, the staffing and everything that it can be a problem. But it might be something to at least look at. Timing of queries. Pardon me. It is up to the organization to decide when queries can be posed. However, from my experience has been that a lot of times payers will oftentimes not accept queries asked or answered after billing. They just won't accept them. And a lot of times that is in hospital contracts. And I did not put that bullet point in here, but contracts have a lot to do with denials as well. And this is something that if it's a problem in your organization, you might want to look at the contract. Maybe you can get your contract changed, or maybe the hospital changes their process at best practice, because best practice really is to query and receive answers prior to final billing. At least in my experience, that has been best practice. Education. I know you guys educate on a daily basis about CDS or CDI, and I'm just going to talk about a couple things that maybe you haven't thought of. But providers oftentimes have absolutely no idea that denials of their diagnoses even exist. They're very aware about their patients being denied for inpatient status and, in favor of observation, that sort of thing. They're very aware of that, but yeah, flabbergasted is the best word I can think of. Yet when I have shown real denials to providers, and examples with their own patients are going to mean more to them, but you can't always do that. So if you have a couple that you've showed a bunch of providers, just make sure you have the PHI eliminated and show them what's going on. Yeah, it can be very eye-opening. And then also show them their own documentation that led to the denials. Connect those dots for them. You want to tie the denials to queries when applicable. Why are you writing the queries? What's the bottom line purpose? And you really want them to understand you're there to help them. You're not there to be a thorn in their side. You just want to get everything so it matches. That's all. So some of the ways that you might be able to get to educate more, you could excuse me, ask to participate in new resident orientation if you're a teaching hospital. Ask to participate in new attending orientation. Make sure that the new residents or the new attendings, they know what the queries are all about, where they are, how they answer, what the importance is. Get on the agenda for medical staff and departmental meetings. If not included in rounds in your assigned areas, you can certainly ask. I'd be surprised if anybody was told no. You can also get on nursing staff meeting agendas. I've found this to be helpful too, because they can sometimes assist to get queries answered. Not to explain queries, no, but something like, hey, Mr. Jones has a CDI query, make sure you answer it, or just making sure you see it. Just something like that, just to give them a nudge. Excuse me, if they have access to see that. As far as the dietitians go, especially with the recent changes, you want to work with your dietitians, and just something you might want to consider. Do the dietitian notes need change to eliminate a spot for provider signature? Something you might want to discuss in your hospital with your dietitians. Make sure your dietitians understand the rationale why a provider co-signature is likely no longer enough for that nutritional diagnosis to get coded and billed. Good. I really think that's going to be a big way to prevent a lot of the nutritional denials going forward. WIFM. One of the physician advisors I used to work with, he called it WIFM. What's in it for me? You want to connect those dots for the providers. Why should queries be answered thoughtfully, completely, in a timely manner? How does it benefit the provider? It might not benefit the provider directly, but it's going to benefit. Well, it is. But it could, and I'll explain in a couple minutes. But pardon me, a compliant medical record. You don't want it upcoded. You don't want it downcoded either. And I think that's how a lot of medical records have been for a lot of years. They've been downcoded, but nobody told anybody. Nobody knew, until CDI came on the picture. But if it's compliant, it's going to paint an accurate picture of the patient, and then everything's going to fall in place. The reimbursement, the length of stay, the statistics, and the ever important report cards for the hospital and for the physicians. Those are important. The docs don't like to see their names on the front, in big letters on the front page of the newspaper, that their mortality rates are up to here, and and the acuity of the patients are down to here. That's, if things are compliant, it's gonna match up. It's gonna show a true picture. Make it personal, because it is personal. If their child or spouse or parent needs hospital services, they want the best, they want the most up-to-date equipment, necessary specialists, enough nurses, enough environmental control workers to keep the hospital clean, and enough dietary staff to provide specialized diets, nutritious regular meals, snacks, that sort of thing. But you have to have the money coming through the door in order to do all this. So it is personal. And if the bottom line for a hospital is close to turning red, or if it's in the red, CDI can make a big difference between enough of these types of things, enough, they can get the equipment updated. They can buy that updated CAT scanner or get the part that it needs, or, whatever. Get that extra neurosurgeon. CDI can make a huge difference with all of that. Okay, I'm going to tell you a real story here in a minute, but we're going to pretend there's a Dr. Doe, and he's famous for not answering queries. We've got Dr. Does everywhere. So what can you do to get a query answered to try and prevent a denial? Well, there's a lot of things you can do, but one thing, you can involve your physician advisor to speak with Dr. Doe and explain the ramifications of not answering queries. At times, a physician advisor is going to they're going to have the ear of the other physician a little more sometimes. Not always, but sometimes. Talk to Dr. Doe yourself. This is a real story. This is probably about 15 years ago now, because my kids were still at home. So my particular Dr. Doe, he was famous for not answering questions. He was always on that DNFB list, that discharged but not final billed, because there were queries that he didn't answer, and he just it was a struggle. So every day, in order to get to this particular floor, he walked past my office. And I thought, I'm just going to grab him and I'm going to talk to him. And that's what I did. I got a couple denials, and I saw him going down the hall. I said, Dr. Doe, hey, do you have a couple minutes? Sure. So he came into the office, and then I showed him this is why we query. This is why queries are so important to be answered, because if they're not, this is what happens. And I showed him real denials, his own patients, and he was, I used the word flabbergasted before. I mean, I think his jaw dropped to the floor. He had no idea. And we spent a good bit of time talking. And pictures of my kids, I had them up on the wall, and I knew he had kids too, about the same age as mine. And I said, this is why we do this. Because if my daughter breaks her leg in soccer, or my son in football, or whatever, I want them coming to this hospital. I want the best for them. I want the best equipment. I want the best physicians, the nurses. I want them here. And this is why we do it. And, not so we can upcode, we don't ever want to do that, but just so it's the way, just to get it right. And I'll tell you what, I could see it click. I could see it click. And he was wonderful from there on. He would stop by a couple times a week. He'd poke his head in and ask if there was anything he could do, to help. And I'd make sure if there was anything he could do to help, I let him know. And he did. He answered appropriately. And he was also a teaching physician, and he influenced a lot of residents and his partners even to pay attention to and answer queries. So I like to use that as an example because it works. It works. Queries and appeals connection. Okay, at the start of this presentation, we had a poll. When clinical validation denials are received, is the denial rationale ever shared with your department? And as I said, it was roughly a 60-40 split, which I didn't think it would be that high, and that's good. But a 60-40 split means there's still 40% of you folks who don't have the denial rationale shared with you. So I would suggest that best practice is to have regular communication between the denials and appeals team and the CDI team. And actually, something that works really well is to have the denials and appeals team and the CDI team in the same department. That works really nicely, but that's not always possible. So maybe you have some regular meetings and you talk about what are the top denied diagnoses and why are they being denied? Is there a pattern? And CDI can help, but they need to know what's being denied and why it's being denied. Involve physician advisors in their meetings, in these meetings, so they know what's going on too. Are charts being coded and billed prior to all the queries being answered? That might be more of a managerial question, but it's still, it's an important question. Are charts being coded and billed prior to discharge summaries being done? Sometimes, a lot of times, queries are answered in discharge summaries and diagnoses are clarified or they're ruled out at that time. But if the billing has already been done, it's like all that is for naught. It might end up, or it might be a good thing to look into that. You can help each other even if you are in separate departments. If you all come to a conclusion that there are some gaps in the processes, there's some places that can be shored up, there is strength in numbers. You know, have your data and have your meetings and see what happens. It's important. It's very important. So in summary, clinical validation is a process which involves a clinical review of the case to see whether or not the patient truly possesses the conditions that were documented. Excuse me. Clinical validation is not coding validation. It will not be overturned with coding rationale. You can include some as icing on the cake, but it shouldn't be the meat and potatoes. Queries are appropriate if the medical record doesn't support clinical validation of documented diagnoses. Queries are also appropriate if the only mention of a diagnosis is on a note from a non-provider that has been co-signed by a provider. Educate, and then educate some more, and make it personal. Making it personal, yeah, I found anyhow, it made a huge, huge difference. If the CDI and the denials and appeals departments don't collaborate, I would suggest that you start as soon as you can. Very important. CDI can help prevent denials if they know what's being denied and why. Okay. Pardon me. Let's see if there are any questions. Any questions here? And I don't see any questions. Kristen, did you see any questions?
There was one that was just submitted a couple minutes ago.
Okay.
What is the best path? Well, sorry. What is the best path to take when you have a diagnosis or do not have a diagnosis, but they barely meet the clinical indicators?
Okay. I'm sorry. I couldn't really hear that too well, Kristen.
Oh, I'm sorry. What is the best path to take when you have a diagnosis or do not have a diagnosis, but they barely meet the clinical indicators?
Okay. Yeah, I see the questions now.
Okay.
That's a tough one. What is the best path? Tell you what, let me think about that one, and I'll formulate an answer to that. Okay, and I'll get back to you. All right, with malnutrition, we had a denial because the payer said the MD did not treat or address enough. Okay, yeah, we've seen those too. you have to remember that, as far as I know, there are no criteria like that are generally accepted by the medical community that states there has to be this treatment or that treatment. And I would go after it in that manner, and I would challenge the payer, and I have. In fact, I got a phone call once from one of the physicians who likes to deny that way. And I asked him, I said, okay, show me the peer-reviewed literature that says you can't have severe malnutrition unless you have this, or this. And he couldn't. So I would challenge the when you write your appeal, because it looks like this isn't CDI. We had a denial. I would ask them to quote the peer-reviewed medical literature that states that criteria needs to be met. Otherwise, it's just somebody's opinion, and it's not based in peer-reviewed literature. That's the angle that I would take and have taken. Where was the ACDIS update about physician co-signing? If you look at, you can Google the ACDIS AHDAM guidelines for compliant queries. If you Google something like that, it will come up. There's a 2019 update, and then there's a 2022 update. I'll answer these questions in writing as well. Okay, when a diagnosis is documented in the ED, that's the reason they are admitted, but then the clinical indicators resolve early. ED is a part of the inpatient stay, and we can code from it, but we are being told that since it resolved early, we shouldn't capture that. Well, if that was the reason for admission, sometimes people do get better quicker than expected, and just because somebody gets quicker than expected doesn't necessarily mean they didn't have the problem. Was it treated? Now in that situation, I would also include a bit of a coding rationale in the appeal too, because that question isn't really about clinical validation. They're not saying a diagnosis didn't exist. They're saying it just resolved early. So that would be more in a coding realm. I would call that a coding denial rather than a clinical validation. And I would go after that from the standpoint of coding rules and regulations. If it's what made it reportable. It wasn't a historical diagnosis. They obviously did something if it resolved quickly, I would guess. I would go after it from that angle. Okay, are those the only questions? Kristen, do you see any more questions?
I don't see any other ones. It looks like we hit most of them. Yep.
Okay. Okay. Well, I'll give you a couple more minutes. Another minute or so, if anybody has any questions. And then I guess I can give you back about 10 minutes of your time. So
one more, looks like.
Okay.
One last one.
We had a denial for obesity when there was a typo for weight. How would you appeal that? Well, I guess, how do you know? Are you sure it was a typo? Sometimes you can't appeal everything. So if the weight, let me think about that one. Okay. And I will get back to you. 3 consecutive days of greater than 45. Fourth day was 25 kilograms per. Boy, that's gonna be a tough one. That'll be a tough one to appeal. A query would have been really appropriate in that. Probably what I would do is I would probably appeal that there seems to have been a typo on page whatever it was, but the documentation was very consistent on these other pages, these other documents, and I think I'd probably, if I appealed it, I'd probably go after it in that manner. I don't know how high a success rate that might be. Excuse me. So yeah, that would have been a good query opportunity. We did that and they upheld it. Yeah, I'm not too surprised because there's conflicting documentation there. So that's why it would have been a perfect setting for a query pre-bill. Yeah, I'm not surprised they upheld that, because that truly is conflicting documentation. So there again, that's more a coding denial rather than a clinical validation. But yeah, all good questions. Okay. Well, unless something else comes in the next 30 seconds or so, there are a couple that I will get back to you about. And again, I appreciate very much being invited, and I hope this was helpful. And I hope you all have a fantastic rest of your day. And thank you again. Okay. Bye now.